Welcome, everyone. Thank you for joining us for this webinar focused on the corporate transformation of healthcare. We are so delighted you can join us today. My name is Sabrina Corlette, and I am a research professor and co-director of the Center on Health Insurance Reforms at Georgetown University's McCourt School of Public Policy. I will be your moderator today as we delve into the corporate transformation of healthcare. I'm really looking forward to today's discussion, which is the first in a three-part series. Next slide, please. For those of you not familiar with our center, we are a team of experts that focus on health coverage and healthcare markets. As policy researchers and analysts, we study how federal and state policies affect how people access, afford, and use healthcare services. We publish research studies and reports, and we also provide technical assistance to federal and state officials and to other healthcare stakeholders. Next slide, please. Before we begin, I want to thank the sponsors of today's webinar, Arnold Ventures, and go over a few quick logistics. First of all, this webinar is being recorded. Everyone who's registered will receive an email early next week with a link to the recording, and that recording will also be posted on our website. Second, we welcome you to use the chat to introduce yourselves, share reactions, and connect with one another. We will also be using the chat to share resources, including a new fact sheet that our center has published on how policymakers and stakeholders can support patients and consumers confronting billing issues. And if you have any technical challenges or problems, please drop those into the chat, and our producer, Nikita Binanula, will do her best to help you. Finally, this is a discussion, and while I will be asking our guests some of my own questions, we really hope that you will submit your questions for our speakers. You can drop those into the question and answer or Q&A box at the bottom of your screen at any time during the webinar, and we will do our very best to respond to as many questions as we can. Okay, now that we've covered those logistics, I am going to dive right into introductions because I am so excited to introduce today's terrific speakers. First, we are joined by Dr. Elisabeth Rosenthal. She is a senior contributing editor at KFF Health News and the brains behind their Bill of the Month series, which documents through often eye-popping and heartbreaking personal stories the medical billing challenges that so many Americans face. She is the author of the 2017 New York Times bestseller, An American Sickness: How Healthcare Became Big Business and How You Can Take It Back. Before coming to KFF Health News in 2016, she spent 22 years as a reporter, foreign correspondent, and senior writer at the New York Times. Her 2013 and 14 New York Times series, Paying Till It Hurts, won numerous awards and is credited with catalyzing a national conversation about America's high-priced healthcare. Next, we have Patricia Kelmar, Senior Director at Healthcare Campaigns, the United States Public Interest Research Group. U.S. PIRG advocates for patients and consumers to bring down healthcare costs and advance policies that limit aggressive and unreasonable billing practices. And lastly, but most definitely not least, we have Dr. Vicki Norton, and she is president-elect of the American Academy of Emergency Medicine. ER docs have been at the front lines of the corporate takeover of healthcare, and Dr. Norton can speak to what it's meant for physicians' ability to deliver high-quality, personalized healthcare. Today's conversation is such an important one. We've all read the headlines about private equity getting into the business of healthcare. We've followed the saga of Steward Hospital's bankruptcy, as well as other major health systems bankruptcies. We've watched our local healthcare markets become increasingly consolidated, and as these systems with market power push prices higher and put healthcare more out of reach for regular Americans. Elected officials across the country are witnessing this transformation in their own backyards and weighing how to preserve healthcare access and quality, increase affordability, and keep healthcare financially sustainable. Over the course of our three-part series, we hope to give you the information you need to understand the forces that are at play, and also to assess different ways that policymakers can take action to foster a healthy healthcare market and to prevent corporations from extracting all the resources and forcing us into a bad deal. At CHIR, we do our research and policy analysis. As we do that, we are guided by the patient experience. And that's why we're starting this webinar series by focusing on what the corporate transformation of healthcare means for patients and for the physicians that serve them. And that's why we've enlisted the help of our three terrific speakers today. We will hear first from Dr. Rosenthal and then dive into a brief panel discussion before opening it up to your questions. I'll hand it over to Elisabeth now.
Having me, and I guess the big question for me is, are our policymakers doing enough, and could they do more? And let's think about this as you hear some of these stories. I got interested in this when I wrote this book, An American Sickness. I trained as an ER doctor, and I lived overseas for 10 years, so I had no idea when I came back why the prices were so high, why my insurance, which had covered everything in the late 90s, now seemed to cover much, much less. So, and what I came to conclude after doing a lot of research on this book, which we all know now, I think, is that the driving force of our healthcare system is profit. It's the business values, return on investment, efficiency, profit. And caring is a distant second, and those are not the values of healthcare. So, why did business come into our healthcare system? I think as insurance grew, because that's where the money is. It's like why Willie Sutton robs banks. There's over $4 trillion sloshing around, much of it for the taking. And it was the natural kind of next feeding ground for private equity, which I had not even really foreseen when I wrote this book in 2017. So it's become really dystopian. Patients are pawns in a war of corporate giants. The person who says you can't get that care is called a patient care advocate. Patients are customers or worse, guests. And our illnesses are a journey. And as you listen to these I'm going to flip through a bunch of our stories from Bill of the Month and our series Diagnosis Debt, which I encourage you to flip through. It's shocking, it's appalling. How is this stuff legal? When I speak to groups of lawyers, I'm like, wait, if this happened in like construction or supermarkets, you would say, no, that's ridiculous. That's not help. But there's no CMS police, and we really need to help or push our regulators to do more. So next slide, please. Can I get the next slide? Just quickly, because I couldn't resist. Our hospitals have become like luxury hotels. This was a quiz we did at the New York Times. Is this a hospital or a hotel? You can Google it online. It's 12 slides. And this is a hospital in New Jersey. And why are we paying so much? And why do we value like luxury in our hospitals rather than care? It's because they're businesses. They're like hotels now. Next slide, which I'm just going to pass over because we need to get going. This is from our series called Diagnosis Debt, where Noam Levy, one of our correspondents, went through. A lot of medical debt is hidden in credit card debts. So he got some access to the credit cards and estimated that 100 million people in America are saddled with healthcare debt. These are some of them. This is a family that had twins who were born prematurely, and between the out-of-pocket costs for their insurance, everyone you're going to see in this presentation has insurance. They ended up with $80,000 in medical bills. They had to move back home. Allison is a nurse practitioner. She had to take on extra shifts. And she said, our goal is just not to be homeless. Next. And this is an issue that where it affects Black populations more than white. 56% of American Black adults have medical debt compared to 37% of white American adults. And this is a woman who had cancer, again, insured, had $10,000 in medical debt, and see how these hospitals operate. They would not let her attend follow-up treatments because she hadn't paid her hospital bill. So, it really affects patients terribly, and a true healthcare institution wouldn't do that. Next. Now you're going to see people from Bill of the Month. This is a patient, Peggy Dula. She and her sisters got in a car accident. They were each taken by different ambulances to different hospitals. She really wasn't injured. And, when I tripped on the sidewalk in New York and some people said, you should call an ambulance, I was like, I will walk to the hospital bloodied rather than get in an ambulance because I know what bills are like. So she owed $3,000. All three ambulances were from fire departments, but they were owned by private equity, and she paid the bill, or she had it in collections. Next. This is Elise Greenblatt. She went overseas and thought she had a sinus infection. She goes to Mount Sinai Group Practice in New York. She asked for a telehealth visit. And basically what happened is she got a bill for $600. Okay, not much, but according to her plan, it's in network and it should have been a $15 copay. But what happened is one of the doctors in the practice, the one who happened to take the call, was out of network. She had no way of knowing that, and ended up with this huge bill. And guess what? The reason they said she had to pay it is because one of those forms you sign when you, which you don't even look at. You really can't even see them when you go into a hospital or agree to a visit, says, I will pay for services that are out of network. And I think, that form has to change. People have to know that their provider may be out of network, even though the practice is in network. Next. This is a fun one too. This is what's her name? This is Sarah England. I know all these people. Her baby Amari had heart problems. He got RSV. She lives in the Central Valley of California. They said Amari needed to be transported to UCSF to be in the intensive care unit. They said we've got a helicopter for transport. They did the transport. The insurers said, no, we think you could have driven. He probably would have lived. Again, what can you do about something like that? Really nothing. She's stuck with the bill. Next. And this is really a fun one too, if there wasn't so horrible. This woman had, she was going in to have her tubes tied, and the doctor noticed some endometriosis. And so he cleaned that up while he was there. And then the hospital billed for 2 different surgeries. So she ended up, she said, no, I'm not paying for 2 surgeries. I didn't consent to the second one, and it wasn't even really a separate surgery. And she ended up being sued over $10,000 that went to collections. Next. This is another one. These are crazy practices that shouldn't be legal. This woman, Eloise Reynolds, her husband died. She paid the bills, and many insurers now go back and re-audit old bills. And so more than a year after he died, they said, "Oh, we've re-audited your husband's billing, and now you owe $10,000." Really? How is that legal? Next, please. Again, this is another one. This Thomas Green, he had bypass surgery in his leg, peripheral bypass surgery, and the anesthesia provider, which was, private equity owned, billed too late. They billed more than a year after the procedure, and so Medicare, according to its policies, said, well, we're not going to pay. So the hospital went after the Greens. But how is that legal? Next. This is, I think, our last one. This is a wonderful Sovereign Valentine. He's a personal trainer in Montana. That's his wife, who's a doctor, an ER doctor, I think. Actually, no, she's a primary care doctor. So Sav was feeling really crappy, and he was diagnosed with kidney failure. And, after 90 days, Medicare kicks in to pay for end-stage renal disease. But in those first 90 days, there are basically two companies, and this is where it comes into the consolidation that do 70% of dialysis in the U.S. end-stage renal disease. And their goal seems to be to get as much out of patients in those 90 days before Medicare kicks in. They tried to bill the Valentines for $500,000, saying they should have gone to an in-network facility in another state, even though they'd gotten approval to go out of network in their own state. So this is just some of the kind of cruelty that's inflicted on patients. And, I'm always asking, like, why is this legal? Why are patients always left holding the bag? And I think it's because our policymakers and our employers, that they don't really vet these bills, and it's easier to pay than to fight them one by one. So I do think we need better laws to ensure and protect patients. I'll leave it at that. I hope you're scared.
Boy, thank you, Elisabeth. So that was truly eye-opening and frankly quite unsettling to hear how profit over patients is put into action. I know our two other speakers have a lot more to add here, so I'm going to just kick things off by asking a couple questions of my own, and then we'll turn it to the audience. I'll start with you, Patricia, if that's okay. We just heard Elisabeth talk about how we increasingly have a healthcare system that puts profit first and caring as a distant second. Elisabeth described it as dystopian and patients being pawns in a world of corporate giants. Patricia, in your work as an advocate for consumers, what is your best advice for folks who are just looking to get the care that they need?
Yeah, thank you, and thanks for being here, for inviting me to be here, and thanks to everybody on the call. As Dr. Rosenthal said, right, even people with good insurance are facing really significant out-of-pocket payments. And as a consumer advocacy organization, we are really focused on high-value healthcare. So, what are the prices for the care that we're getting, and is that giving us better outcomes, right? And so if we can keep our eye on the prize for high value healthcare and get rid of all the low value healthcare and the upcharging and the overcharges, that will be better for individual patients and for the system as a whole, right? We know that we are just paying so much as a country on healthcare, and individual patients are paying a lot themselves on their family budget. So long gone are the days of charity-driven provided care, right? We are living in a world where our healthcare is delivered under the decision-making and the design of a corporation, a healthcare business. So profit and loss statements, mergers, and building market share, that is what is occupying the minds of our C-suites of our hospital systems and healthcare systems around the country. And oftentimes that means, the patient is the last person to be considered. So it's really challenging for folks. And I just thought I would mention, Dr. Rosenthal went through a lot of the issues that people who call me tell me about, but I thought I would just bring up a few other situations where, despite really good and active engagement in looking at your healthcare bills and thinking about the prices that you're going to be paying and how much you're paying, some of the traps we're in, right? So we're always told, stay in network, right? That's how you're going to pay less out of pocket. But we all know that our insurer network directories are notoriously bad and outdated. So it's not enough to just look on your website and see if that provider is listed as in network. You have to actually call and confirm, and even the day of, confirm that that provider is still in network. It's a burden, and if they're not in network and you didn't realize that, then you're stuck with that out of network bill and those added charges. The other thing that trips up people is that prior authorization, right? So prior authorization, if used well, is actually trying to keep an eye on making sure that patients are getting what they actually need and not being offered and told that they should get services or drugs that aren't indicated. So the situation, though, is often that either the provider drops the ball and doesn't know that prior authorization is needed, or the hoops and hurdles that they have to jump through to get that many times leaves the patient getting care, not having the necessary prior authorization, and again, paying the full freight of the prices for that care that wasn't authorized prior. So that's another trap for folks. And then there's the crazy things like, you think you went to the local urgent care center, but in fact, it's licensed as an off-campus emergency room. So you went to get a strep test and you get billed as if it was an emergency room strep test, and your insurance says, forget it, we're not paying. Strep tests are not emergency room treatments. And again, the consumer with that denial is ending up paying that full amount. So those are just some of the different things that we're seeing. And as consolidation happens, we see more doctors being owned by hospitals. And that changes the billing practices. And I know Dr. Norton will probably talk a lot about this, but suddenly people are seeing, for a regular doctor's visit, the doctor they've been seeing for years, they're getting an additional facility fee charge, which can be $50 or several $100s. And they're getting billed at a hospital rate, right? Because now suddenly the hospital billing code is being used instead of a regular provider code for those services. So those add costs to the system. All of those upcharges aren't actually giving us any better care. And that's the frustration. And those are the kinds of things we should be spending our time finding solutions for.
Thank you, Patricia. I'm going to turn it to you now, Dr. Norton. How is this playing out for physicians? These profit motives, like, what do they mean for the hospital floor, the doctor's office? How is this impacting your members' abilities to deliver high quality care?
Yeah, thank you so much. That's a really important issue, and there's definitely a fundamental conflict between safe and quality patient care and the maximization of profits. So as physicians, we're experiencing numerous cost-cutting measures that are implemented by these businesses that own physician practices or hospitals that are a detriment to our practice. We see understaffing, whether it be with physicians primarily or with support staff like nurses, techs, even like housekeeping. Like that can affect the patient flow in the hospital, going up to a room upstairs if there's not enough housekeeping staff. We're seeing it in terms of physicians being replaced with non-physicians. Like you make an appointment with a doctor and you're actually going in to see the nurse practitioner or the PA. And you're seeing higher and higher ratios of non-physicians being staffed and being supervised by physicians, but the physicians can't really supervise because the staffing is at an inappropriate ratio where they can't actually be in charge of that many people at once. We're seeing that there's this big focus on charting We're basically being pulled from the bedside to complete a chart, which is really just a billing vehicle, right? That chart has nothing to do with how well I care for the patient. It covers me medically, legally, and is a vehicle for billing for the corporation that you work for, and doesn't really help me take better care of the patient. And then in terms of transparency, we talked about transparency on the patient side. Well, there's no transparency on the physician side either. Up to 80% of physicians are employed right now. And that number should scare you, because pre-pandemic in 2019, it had just come over 50% for the first time ever. And now it's 80%. So in the 5 years since the pandemic, we've had rapid consolidation of hospitals buying up physician practices, of private equity buying up physician practices. And essentially, everything becomes opaque. We don't know what's being billed and collected in our name. We have no say over what's being billed and collected in our name. And I mean, this is a big issue, because then patients are looking at us like we're the bad guys. Physicians are responsible for this huge bill that they're getting. But really, I have no control over that bill if I'm working for a private equity-backed staffing firm. They're the ones that are saying, oh, we're going to charge out of network. Even though the hospital is in network, my staffing company that I'm employed by is going to go out of network, because that's how they can maximize their profits. So we have no control over that. I can't negotiate with a KKR-backed staffing company who makes trillions of dollars a year as a single physician, and even, as smaller physician groups. So that's a real problem on the physician end. There's no transparency there either. And then the facility fees, especially in the emergency department, are massive. Massive facility fees, thousands of dollars, that, again, the patients are looking at this bill thinking that the doctor is responsible for giving that thousands of dollars bill. But on our end, like, we have no idea what the facility fees are. We have no idea or control over what the hospital's charging, because we might work directly for the hospital, or we might work for a staffing company that, is controlling everything we're billing, and they have no say over what the hospital does. So, I mean, that's a big issue. And, in terms of like physician compensation, for the last 20 years, physicians have received cuts in Medicare reimbursement every year for the last 20 years, whereas hospitals have received bumps in Medicare reimbursement. So as we're seeing that, that's why a lot of these things are happening with like going out of network and things like that, because reimbursement just keeps going down on the physician end. And these businesses, you'll see it more rampant with private equity-backed companies that employ physicians, that they're going to try to maximize the payments to the physicians, but it's really going into their own pockets, and they're going to end up just increasing the amount they're billing and going out of network more often.
Thank you, Dr. Norton. So this is really a question for all three of you, and I invite whichever one of you wants to go first. But what is your advice for policymakers? We have on this webinar, we have state level policymakers, but also some federal level folks. What would you recommend first? Like, how can they learn more about what is going on in their district or state? What can be done from a policy perspective?
Well, I'll speak to that a little bit. I think a lot can be done. You could say, I talked about the woman who went to just a video visit for a sinus infection and was billed out of network. The other thing that was extraordinary is there was a facility fee, and I'm like, I'm sitting in my living room. The doctor is sitting in his house upstate. So where's the facility? So I think, a lot of the things that open up during the pandemic should be shut down. I mean, video visits are good and fine for certain things, but a facility fee, that idea is uniquely American. So, the idea that you're paying for the building when you go into a drugstore, do you pay a facility fee for, CVS? It's a billing construct. And I think what Dr. Norton was speaking about is how this happened is, when I worked as an ER doctor 35 years ago, I just came with the ER, you know, I had a salary from the hospital. So this disaggregation of billing and the separation of billing, of care from billing, you know, there are now companies that most hospitals contract out to do the billing, and they look through the charts and try and maximize billing. So you know, when people come to us, which I love for bill of the month, they'll say like, I'm going to report you to bill of the month. You know, we shouldn't be the answer to this. You know, we're the last resort. They've usually gone to their congressman, their senator. You know, we have very determined patients. And you know, I think part of it is CMS needs to make clearer to insurers what they can and can't bill for. And you know, when you look at, I hate to say it, but when you look at the difference between our country and our spending and other countries, two things pop out. In other countries, there are a lot of prohibitions about for-profit healthcare. Insurers used to be, remember how much of our healthcare dollars go to profit? You know, I think it's extraordinary right now. I'm not saying that it should be none, but, and the other thing is every other country has some kind of price setting. You know, these are reasonable fees. And could we get there in the US? Maryland does it. Could a state do other states do it? It's very hard right now because Maryland did it a long time ago, and I always joke, oh, well, the hospital association must not be, no, I've been very powerful then. Now the hospital associations in every state are, you know, they're big political donors, they're big job creators, and I think, you know, the hospitals really have to be, and the private equity firms, there has to be some kind of limit on how billing happens and more restrictions on reporting to credit agencies. And but that's so like drop in the bucket compared to the fundamental question of, do we want to have, how do we get prices at a reasonable level? And how can we protect patients from a wily industry that when you pass the No Surprises Act, right, which is a great thing, how is it that ground ambulances aren't included in that? You know, well, there must be some lobbying there. And what we see again and again is providers getting around that act by having patients, you know, sign these forms that are kind of endlessly disclaiming what you can be charged for, and you're sick and you don't read them. And what are you going to do? You're in the emergency room. You're not going to not sign, right? So I think, you know, patients need an advocate, really. They're dealing with this one-on-one, and gosh, I don't know why representatives, state representatives, local representatives, attorney general don't take this on in a bigger way, because they would get a lot more votes if they did. Sorry,
Absolutely.
Thank you.
I'm ranting a little bit now.
I would like to just touch on that too. I mean, we talk about like having patient advocates. I think physicians have been vilified in the last like several decades, that we are not the patient advocates. And I would say that that is completely wrong. And I feel like it's a campaign against physicians, that, you know, we're the ones that take an oath to do no harm, that we're the ones on the ground taking care of the patients. And now we're the ones that are, you know, being employed by these entities that are taking advantage of patients. And that's leading to just a ton of burnout, a ton of moral injury. You know, physicians are demoralized. They can't do anything to fight against this system. And we're trying to be the patient advocates, and we're failing at it because we're just another cog in the wheel. And so I just want people to realize that. And so I think some of the advice for policymakers that I have is, we need to restore a little bit of the balance in physician autonomy and between physicians and business. And part of that is restoring the corporate practice and medicine prohibition. 33 states have this prohibition on the books in some form, where there's a separation between physicians managing their practice and the business interest. And, you know, really says in some states, like a hospital can't employ a physician because the hospitals can sometimes have too much undue influence on how you practice medicine. Same thing with insurers. United Healthcare is currently the largest employer of physicians in this country, and that should scare people because there's so much vertical integration in insurance now that they're not only the payers, they're also now the providers, and they're also controlling the prescriptions, the medications. So that should really scare people. And I think that's a focus, really enforcing corporate practice and medicine laws in states that have them, in states that don't have them, instituting some kind of prohibition so that there's this separation between the business interest and the practice of medicine. And then also, breaking up some of this vertical integration that's really leading to a system where these megaliths of insurance companies can just they're controlling every aspect of your healthcare and making hand over foot profits that we've never seen before. And it's obscene. It's obscene, and it shouldn't be happening in this country. So I hope that's what people could take away from this, is that we need to really rein in those profits. So I agree 100% with Dr. Rosenthal on that needs to be a focus.
Okay, we're getting a bunch of questions in the Q&A box, and just a
Could
reminder.
I jump in to answer
Yes,
that?
yes, I was going to
Thank
turn
you.
to you. Before I turn
Yeah.
to audience Q&A, I want to make sure, Patricia, you get a moment to share your thoughts as well.
Thanks. And yeah, I would just say, first of all, the states have really been quite creative. They've been tired of waiting for Congress, frankly, to solve some of these problems. So they've been thinking about this. And I would just say, if folks could think of that high value definition again, right? Like, some care is just going to be expensive. But that's okay if we're really getting the outcomes and if the prices are tied to actual underlying costs. So if we can kind of keep that as the way to evaluate how pricing should be done and how policies should be written, is understanding real costs, like what are the real costs? Dr. Rosenthal showed the fancy lobby. So are hospitals that are going under, are they going under because they use Carrera marble, or are they going under because the payment system is wrong? So I think we need a lot more transparency. States could do a lot more to get that information, look at where the costs are, see if the value is there, and make solutions based on that. And I think that would drive us to, smart policy solutions. I do warn against, although it feels like a good and easy thing and good thing to do for consumers, straight out of pocket caps, because if you're not addressing the underlying prices, what happens is it's just a cost shift. Now insurers are paying more if you haven't addressed the actual prices. And so we'll all be paying more in premiums, and that will just cost our system overall. Plus, it just cuts us off at the knees for advocates like ourselves. If the patients aren't feeling the pain, it's really hard for us to activate them and get them engaged in fighting for these bigger solutions, right? For these broader system-wide solutions. So we really want to make sure that we keep people engaged in the system, protect them when they have no individual power to protect themselves, but look for the ways to cut costs that don't impact patient care. And that's the things like Dr. Rosenthal said, right? Ambulance surprise billing, facility fees. We have this concept of site neutral payments where we're just paying one price no matter where the thing happens. New York State has a bill to do it in their state. Congress has talked about it on the federal level. So these are the kinds of things that can really bring down prices, and we haven't hurt the patient in any way. They still have access.
Great. Thank you, Patricia. Thank you to our panel. We've got a bunch of questions lining up in the Q&A box. So I'm just going to start with the first one that came in, and we've talked a little bit about consolidation and high concentration. This question is asking about the importance of that within nonprofit systems as well as for-profit systems. Elisabeth, you mentioned, we've got a lot of for-profit healthcare in this country, but I would love to hear a little bit, like, is there a real distinction in behavior between nonprofit and for-profit systems?
No, I'm so glad someone asked this question because, no No, basically, our not-for-profit hospitals, and this is something that that policymakers could take on if these not-for-profit hospitals weren't so powerful politically. They are big corporations. They call their profits surpluses because by definition, they can't have a profit. They engage in for-profit ventures. They build hospitals overseas that are for-profit. They have joint venture companies. They have investors in technology. They're acting pretty much just like a for-profit and not paying the taxes. You know, they in theory uh, are not get their tax exempt status because they deliver community care, charity care and community benefit. And they do a little bit of that, although most studies show not enough. But they otherwise are acting like just big corporations. We had a funny article, the Cleveland, I hate to name check people, but anyway, the Cleveland Clinic has built a for-profit hospital, fancy, across from Buckingham Palace. And when I asked our reporter, Jordan Rao, asked them how this benefits the people of Cleveland, the answer was something ridiculous like, oh, well, we've learned how to share x-rays better. You know, I think we have to go after these big monoliths and say to them, you know, either pay your taxes and then the community can use that money for better health, um, or really do more for the community, stop this stuff. But again, no policing of this, you know, I don't know who the police would be to go after this. It's really mayors and state officials that have taken on hospital systems. And the problem is mayors and state officials aren't lawyered up the way these big hospitals are anymore. So it's really something that should be addressed, but it's hard to see how it's going to be addressed.
Thank you. Vicki, I'm going to ask you sort of two related questions, I think. One is if you could talk a little bit about why staffing firms are increasingly being used. Is it a hospital decision or a doctor decision, and what might change that? So that's one question. And then I think this is related, but another question came in asking if employed physicians are restrained by gag clauses.
Yeah, sure. So I mean, emergency medicine was one of the first specialties to see these staffing companies come in and take over. I think it's an easy button for a lot of hospitals, especially if you're like in a big system. It's like your one-stop, you know, staffing needs. And sometimes the staffing companies will come in and say, well, we'll do your radiology, your anesthesia, and your emergency department staffing all in one. And basically sometimes like undercut the physician group that's there through these like kind of backdoor deals of like, okay, we're going to do all your staffing for you. So the physician group sometimes might be getting a subsidy because of, you know, if the payer mix in the area can't support, you know, staffing appropriately for the emergency department, sometimes the hospital will pay a subsidy, but sometimes these bigger conglomerate physician staffing companies will come in and say, well, we'll do it and we won't take a subsidy, because they'll just take that little loss in the grand scheme of things of being able to staff all these multiple specialties and hospitals. Or they'll use one specialty's reimbursement to kind of cover the loss from another specialty, which happens a lot in the emergency room. Like we might be paying for the loss that's happening in anesthesia or radiology if we're staffing in multiple specialties. So that's one of the ways that it got a footing, because it was just easier. And it is a way sometimes for the hospital to bypass due process rights for physicians. So CMS guarantees due process rights for physicians working at a hospital if they're part of the medical staff as a part of a condition of participation in Medicare and Medicaid. And so if you're on medical staff at a hospital, you're supposed to be offered due process if there's ever a question of, you know, whether you should lose your medical staff privileges. However, if you work for a third party, they make you sign that away. So now physicians are being terminated for speaking up for patient safety issues. They're being terminated for bringing up like questions about billing and things like that. So it's become a real problem where now your physician can't advocate for you because not only did they sign away their due process rights, but they also signed a non-compete in that same contract. So even though they're an employee with no trade secret knowledge, they got all their knowledge from medical school, not from the private equity firm that was paying their paycheck the last couple of years. So, there's no reason that a physician employee should be signing a non-compete, especially in the emergency department. So those are the main issues that are happening with these staffing firms. So sometimes, the hospital then can have more ability to interchange any physicians that they maybe don't like if you're making too many waves about, proper patient care and safety issues. If you're seen as a bad egg or something, they can just interchange, put the next physician in because the staffing company is the one that's going to pull the eject button. And we've seen that with Dr. Ming Lin in Seattle during the pandemic, who unfortunately had the gall to advocate for proper personal protective equipment for his fellow physicians and nurses and staff at the hospital. And as a result was fired by the staffing company that was contracted with the hospital. So he's still undergoing litigation for wrongful termination for that. But not a lot of physicians will do that. A lot of physicians will just, I need to get another job and just keep quiet and move on to the next job and not fight it. And that's why you don't hear about it as often as it's actually happening.
Right.
Sabrina,
Go ahead. Yep.
Can I mention something quickly on that? Because I've asked physicians, when physicians practicing in the ER or at the outpatient clinic, they have orders they put in. They have asked the hospital, like, how much is this going to cost? And they can't get an answer. Like, so if you had on your order sheet, CT scan, $12,000 it's from the ER, you might say get it as an outpatient, but they restrict information about price to physicians, so physicians can't protect patients in that way.
Correct. I've tried to help patients before when they ask me how much something costs, and our hospital has a website that's supposed to have transparency of pricing. And it is so many hoops to jump through to get an answer because you have to put in your insurance, like it's not an easy, there's no cash price list that you can see easily anywhere. And if you try to put in that you don't have insurance on that website and go through the form, it's still it's hard to get an answer. So it is very difficult.
Thank you. I do want to flag that we've been getting some great questions coming into the Q&A box. There's also a lively discussion in the chat and some great comments going into the chat. So thank you for your contributions. I think we have time for just one more question because we did promise to finish up at 1:55 and give everybody time to move on to their next thing. So I guess this one maybe I will pose to Patricia. This question is, are caps on out-of-network prices a viable policy solution as Oregon has done? Is that something you're familiar with?
Out-of-network prices?
Mm-hmm.
So, in the Ground Ambulance Advisory Committee that I served on, there was a recommendation for capping the the copay of somebody who's calling for an ambulance, right? Because understanding that in many communities, 100% of the time that you call for that ambulance, it will be out of network because the ambulance that's contracted for that community does not have a contract. So in cases like that, I think we have to step in, right? It's really a monopoly. It's one ambulance company. If our insurance is hiding behind the fact that they don't have a network and they're pushing us to pay that out of network rate, then yeah, that would be a situation where really, policy should step in. This is not a market system where we can have competition or we can choose which ambulance. So I think that makes sense to have, those kinds of caps in those situations.
Mm-hmm.
As an organization, we tend to want the market to work and to bring prices to the market, but we know that there's a lot of things within the healthcare system, and as consolidation grows, we aren't seeing the kinds of competition that we need. And oftentimes, the individual consumer can't actually use competition to its benefit. Employers and purchasers, it's a different story, and they're getting better at it, but we still have really highly consolidated markets. So some protections are needed.
Great, thank you. I think that's all the time we're going to have for questions, but we see this as the beginning of a longer term conversation that we hope to have with all of you. I really want to thank Elisabeth, Patricia, and Vicki. Without your experience and expertise, we couldn't have done this. So thank you so much for joining us. This really is just, like I said, the first in a series of webinars examining the corporate transformation of webinar. We hope that you can join us for parts 2 and 3 on February 14th and 28th. Our second webinar, we will be talking about what is driving this trend in healthcare with Dr. Zuri Song, Zach Cooper, and Steve Parente. I know you want to celebrate Valentine's Day with us, so I hope to see you there. We're dropping registration links into the chat if you haven't already signed up. So please please join us for webinars 2 and 3. And then last but not least, before you sign off today, please take a moment to fill out. We have a very short survey that will pop up on your screen. Your feedback is really helpful to us in designing these webinars. I want to thank our panelists again, and the Burness team and Arnold Ventures for allowing us to do this webinar. And we hope to see you next time.